Morning, everybody. Thanks for coming. Thanks for this nice introduction. Today we are going to talk about the personalized external aortic root support, and in particular the Oxford experience with this technique. Before going in the specific of the topics, I would like to talk with you a little bit about the Complex Aortic Surgery Program. So introduce the team and give you an idea of our work with the Complex Aortic MDT and overview of the aortic service. And then we will go in the specific of the personalized aortic root support. And I will give you an introduction of the stent, indication and conventional treatment, a worldwide clinical experience, and the specific Oxford clinical experience. So let's start with introduce the team. You will recognize some of the faces here in the room. So the two main aortic surgeons is Mr. Petri is the head of the program, and Mr. Farid is a consultant who recently joined the team. I'm the senior aortic fellow, and we work obviously with all the team, but specifically with Dr. Hill as an anesthetist. Dr. Jean is our TOE operator that is has a fundamental role in theater, and we got Jasmina here as a surgical practitioner, Scott as one of the scrub nurses, and obviously the team of perfusionists and ODP. So it's a big team, and usually we do our big case on a Wednesday, and sometimes also on a Monday. In July 2017, we established a formal complex aortic MDT, and in the first year, we discussed over 140 cases. So it was a very, very successful first year of such MDT. And the aim of this MDT is to have a multidisciplinary discussion that involves a cardiac surgeon, cardiologist, vascular surgeon, vascular radiologist, anesthetic team, and to provide a referral pathway for both patients and referral doctors to discuss indication and timing for surgery, the surgical planning, the follow-up, and we had also many learning discussions also after difficult case to see how we can improve the service. And here you can see all the doctors involved in this complex surgery, and a word also for our PA, Tracy, that she does a fantastic job. And overview of the patient we treat is with this in the table. You can see the result of our first year audit MDT. So fundamentally, we treat patients with aortic valve disease, aortic aneurysm, pseudoaneurysm, aortic dissection, acute and chronic, bicuspid aortic valve, syndromic aortic disease, including Marfan syndrome, Turner syndrome. We collaborate very close with Dr. Turner from the endocrinology center, and Lois Diaz syndrome patient, endocarditis, homograft and prosthetic degeneration. So the type of surgery we do is aortic valve surgery, including aortic valve repair, and we just started a program of sutureless aortic valve. Aortic root procedure, including total root replacement, valve sparing root replacement, root remodeling and enlargement, ascending and aortic arch replacement, including hemi-arch, total arch, and elephant trunk, and open surgery for descending thoracic aorta, and we do hybrid procedure, the branching and endovascular treatment in collaboration with the vascular team, and the complex redo procedure, and we treat endocarditic, root abscess, and homograft. Looking at our outcome here, I will show you the 3 years. So in cardiac surgery, every surgeon has to publish his result every 3 years. They're published from our society. And the raw mortality for Mr. Petru's surgery for elective surgery was 0. So it was a very, very outstanding result. And on the top graphic, you can see that most of the procedure, there are other procedures, so they are not coronary artery surgeries, isolated AVR or mitral. So that's go in the category really of aortic surgery, most of them. And from a research study that we look in retrospective review of 80 aortic valve reoperation, our mortality for isolated redo aortic valve replacement was 0%, and for redo complex aortic valve surgery, it was 7.7%. And we are talking of a category of patients that they've got a risk predict risk mean of 11-12%. So we are a UK leading center for aortic valve repair and valve sparing root replacement and ROS procedure in adult population and personalized aortic root support. That is what we are going to talk today. In particular, Oxford had a particular leading role in study the role of peers for concomitant mitral valve surgery. So what it is personalized external aortic root support? This is a novel surgical method that for the prevention of aortic root dilatation in patient at risk of aortic dissection. So a replica of the patient aortic root and ascending aorta is constructed combining CT, MRI, and 3D printing technology and surgically implanted around the aorta of the patient. This technique has been developed by a team of engineers and surgeons from Imperial College and Royal Brompton Hospital in London. It is an evolution of the Robicheck technique that was the rapid concept, but the innovative idea was to use a customized and pliant porous mesh that adapts perfectly to the root at the ascending aorta. And most important things, it becomes completely incorporated in the wall, and I will show you the evidence of this. And so this concept was introduced for the first time at the Marfan Association in 2000, and the engineer that is the designer of this technique, Mr. Goldsworthy, was also the first patient to have the stent implanted in May 2004. So really come out with this idea because he's a Marfan patient and he wants to treat himself, and he didn't absolutely want a mechanical valve, and he came out with this clever idea to reduce the risk of the operation. So the manufacturing process involves 4 main steps. So we got the imaging of the aorta. The computer decided to create a modeling of the aorta. Then, using a 3D technology, we created a former, and on top of this former, the stent is constructed. So what's the innovative of this stent? The difference is that the material that is the same material that we use for conventional graft, but the conventional graft is a low porosity graft, so it's a stiff graft that has got a corrugate aspect and allow it to bend without occluding. That is what you want really when you completely replace a vessel. This stent is a knitted macropose mesh. So it's easy to implant. It's got a strength that anyway prevent any enlargement of the aorta, but it's got microporous of 0.7 millimeters. So it's allowed the tissue to grow within the porous, and that's why it gets completely incorporated into the aortic wall. The idea of using macropose mesh was already described in the early 1890s, and there was already evidence that it got completely incorporated in the aortic wall. There are 2 ship models with the exovascular stent. In one model, the stent was applied to the carotid artery of 6 growing sheep, and and after 4-6 months, the artery were removed and analyzed, and the mechanical evaluation showed 5-fold increase in maximum tensile strength of the area that was covered by the stent, and the histological exam showed that the mesh became completely embedded in the wall. In the second animal study, the graft was put around the aorta of the sheep, and on your left side you can see a conventional graft. So you can see how the graft created a shell around the aorta and the space between the native aorta and the stent, and this is the whole technique. With this innovative technique, the stent got completely embedded in the aortic wall and became a single layer, so there's a massive difference. So what are the indications for personalized aortic root support? So this procedure is indicated in patients with dilatation of the proximal aorta and competent aortic valve. The large cohort of patients treated are Marfan patients. We all know that in Marfan patients, aortic dissection is the most common cause of death in the natural history of Marfan patients. And surgical treatment is the most important prolonged treatment we can offer. These are the 2014 aortic thoracic guidelines, confirmed also in the 2017 valvular heart disease guidelines, that establish that replacement of ascending aorta for Marfan syndrome is recommended when diameter maximum of 50 or 45 if there are concomitant risk factors. There are other conditions that kind of patients that we also treat where we can, because they are very aggressive disease, a low threshold has been recommended to treat this patient. And these involve Lloyd disc syndrome, Turner syndrome, and Ehlers-Danlos syndrome. The conventional treatment, we go really, the classical conventional treatment is the total root replacement, or what we call Bentall operation, and we just celebrate the 50 years of this procedure. And so we use a composite graft, so there's a graft with a valve inside that could be a mechanical valve, or you can, tailor by yourself one with a tissue valve. Is an effective, safe, reproducible, and durable operation, and it can be performed irrespectively of the function of the valve, the size of the aneurysm, and is very reproducible, so there's no much of surgeon variability. But the problem is that you go an artificial valve, and particularly if you go a mechanical valve in a young patient, like probably is a Marfan patient with, that requires just prophylactic surgery, means that this patient needs to be on anticoagulation for the rest of his life. So to avoid this problem, in the early 80s, two new techniques have been developed to try to preserve the valve. And these are the remodeling technique and the reimplantation technique. They probably now are considered the gold standard for this type of patients. And we got excellent long-term result with valve-sparing root procedure in a very big, high-specialized aortic center. But surgical registry meta-analysis show worrying variability between center, and particularly between surgeon. And this is probably because this procedure is very technically demanded and is based on surgeon experience and a series of judgment and technical skills, largely based on the surgeon's experience. So here is where the peers come, really. So the peers is just prophylactic surgery, so it can be done just before the aneurysm gets too big or the valve leaks. And so it's usually offered to young, active asymptomatic patients. So the aim is that to offer a safe and reproducible operation to prevent aortic expansion and the risk of the dissection, but to avoid also the risk correlated with complex aortic surgery like prolonged cardiopulmonary bypass, early recurrence of aortic regurgitation, need for reoperation or thromboembolic events. As for October 2017, 120 patients has been treated worldwide with this technique, and the large cohort of these patients were Marfan syndrome. 124 patients, 3 were converted to conventional root surgery due to intraoperative funding, and 1 patient died, and this is the CT scan of a patient that died. You can see that he had a very distorted anatomy with a severe pectus, and during the mobilization of the tissue to implant the graft, there was a damage of the left main stem. The patient was obviously put on bypass, on ECMO, and actually recovered well after 3-4 days, but unfortunately he had intracranial bleeding 5 days post-surgery and died. 3 female Marfan patients had foreign eventful pregnancy. This is very important because pregnancy is a big risk for Marfan patients, because it's been noticed that during pregnancy the size of the aorta increases and there's a risk of dissection during pregnancy. And 1 patient had the reoperation 6 years after. In this patient, he had some hemodynamical instability in ITU after the first implant of EPS. So the stent was released on the proximal around the sinus sinus because they were worried about compression in the coronary artery. And actually what's happened is a few years after come back because there was a dilatation specifically of that sinus. So this kind of natural experiment showed that in that patient, the area that wasn't covered by the stent, actually the disease progressed. One patient presented with angina 7 years after surgery. Disease is coronary, and the origin of the coronary is completely free, and the problem was a lesion on the LAD that was stented, so it wasn't correlating at all with the stent implant. This is probably the most important experience we go so far, that the patient after 4.5 years from the implant died, and the post-mortem examination showed no sign of aortic dissection, no complication correlated with the stent implant, but the problem was probably a cardiomyopathy, congenital cardiomyopathy that is often associated with Marfan syndrome. So this is the only real histopathology finding we go in a human. And this is important because we confirm what we saw in a sheep, that the graft gets completely abandoned in the aortic wall. But the most important thing is the structure of the media. So on the figure B, you can see the classical degeneration of the media that is characteristic of the Marfan patients. And this is a sample of the arch, of the part that is not covered by the stent. In the figure D, you see the aorta that is covered by the stent, and there's a sign that the media within the implant recovers. And we think that this is because the tensile stress has been removed, it's been supported by the stent, and so there's no pressure on the media and no disintegration of the fiber. 2 MRI studies have been done, and I'll just go quickly to this one to show you that, it's been proved that the stent reduced the peak stress at the level of the sinus, that is the green area. So the first column is the pre-op MRI. The second column is a early MRI post-implant, and the third column is a late MRI. And you can see that the green area that is the peak of the stress disappears from the sinus because it's been supported by the stent. But there's a risk that this can be a little bit dislocated just after the nominate artery, that is exactly where the heart finishes the area that the stent covers. These are the publications so far. So we got the 9-year outcome for the first 30 patients, and there was no event correlated to the aortic valve related events. And so initially this technique was perceived very critical, particularly from the big American unit. But the main issue was that they didn't appreciate the difference between using this kind of stent or using the whole vascular graft to do the proper wrapping. And the most frequent concern were migration of the stent, thinning of the wrapped aorta, aortic dissection within the support, or aortic dilatation behind the support. So the publication of these long clinical results are changing the view of the surgical community on this technique. And there's ongoing discussion about the need to reconsider the decision-making process in Marfan patients. And particularly in view also of the Montgomery case, now we are obliged to our patients to discuss with them on every option we got. And for a young Marfan patient, the priority is to have a low-risk operation, to have a healthy lifestyle, to be off of anticoagulation, to be allowed to get pregnant, and so this is actually could be an ideal technique. And the main Oxford contribution was in study the role of piercing concomitant mitral surgery. So we come with our experience. So a total of 7 patients received an exovasc stent within our team. 5 procedures were performed at the John Radcliffe Hospital and 2 in other UK centers as part of our proctoring service. 3 patients underwent isolated stent implant and 4 concomitant mitral valve repair. All patients had diagnosis of Marfan syndrome. 2 were female. They were a very young patient population with a mean age of 33. So the procedure is done in median sternotomy. The aortic root is dissected down at the level of the annulus. The left and right coronary artery are carefully circumnavigated. And so the exovasc stent that is being constructed, as we say, specifically on the CT of that patient is brought to the table. We go two sides, one 100% and one 95% reduction of the diameter of the native aorta. And there are two markers that mark the site of a coronary artery. And the stent is placed around the ascending aorta and root and proximal to the region of both coronary arteries. So distal is fixed at the level of the nominate artery and proximal at the level of the aortic annulus. Using a 95% stent, so slightly smaller than the native aorta, can help in supporting the aortic annulus and reduce the risk of further aortic regurgitation. When we use this technique in combination with mitral valve repair, the big advantage is that most of the preparation for the root implant is done before going on cardiopulmonary bypass. And the actual implant is done after we release the cross clamp, so once the ischemic time on the heart is finished. And so this technique has a very little impact on the ischemic time. And this means that allowed the surgeon to dedicate a long time to the mitral valve technique. So the first three patients, as we say, had isolated stent implant. The second patient had the previous TIVA for thoracoabdominal aortic dissection, and she developed dilated aortic root, and she had the stent implant. And the fourth patient is the first one that had concomitant mitral valve repair, so it was a P2 scallop resection, and the implant of a 36 millimeter ring was used to support to perform the mitral repair. And this patient had a mild central AR that improved after the position of a stent, and obviously a successful mitral valve repair. This is the second patient who had combined procedure, and you can see the mitral regurgitation and the post-repair intraoperative TOE. They show a nice competent mitral valve. And cardiopulmonary bypass time was 140 minutes. And this is a patient that we helped to do in Bristol, and this is a post-operative chest X-ray. I put there to show you the chest of this patient and how challenging it could be. And actually, he underwent a mitral valve repair, but after the repair, he developed what we call SAM, systolic anterior motion movement. And is a quite common complication, particularly in malformed patients, because the anterior leaflet of the mitral valve often is very large. So this patient required a second round of cardiopulmonary bypass, and the bigger ring was implanted, and the SAM mechanism was abolished. So it was a slightly long cardiopulmonary bypass and cross-clamp of 100 minutes. So think if in a patient like this, you won't even perform a valve-sparing root procedure, it will be a very huge operation. So particularly in patients like this, the stent is really an ideal technique. And the last patient that we treat in Edinburgh, and this patient had severe annular calcification. So again, the repair was uncomplicated, but was quite challenging due to the annular calcification, and it required quite a high number of stitches to implant the annulus. So a review of our little series show that all the patients underwent successful stent implant. All the three cases that had isolated personalized aortic root support, the procedure was performed without requiring any cardiopulmonary bypass. In the fourth case, where we had combined mitral valve repair, the average cardiopulmonary bypass was 145 minutes, and the cross-clamp around 90 minutes. We had no significant residual MR in all the patients. In one patient, the degree of AR improved after the implant of a stent, and no patient required blood transfusion, clotted fracture, or had major complication. ICU length of stay was 1.5 days. In-hospital stay was 6 days, so very smooth post-operative stay. And just one patient that had the previous history of AF was discharged on warfarin. Otherwise, all these patients, they were free from any anticoagulation. We did the MRI scan follow-up, so at the mean of nearly 4 years, and for the first 5 patients, and all the scans show that the size of the aorta is stable and there's no significant progression. And this is the lady that, as I say, had the previous TIVA, and so definitely high risk for aortic dissection, and the proximal part of the aorta is stable after 5 years from the implant. And this is patient 3, and this is the first patient who had concomitant mitral valve repair, and obviously we did also transthoracic echo that confirmed successful mitral regurgitation, mitral repair, and you can see also that the diameter of the ventricle the ventricle is getting smaller with follow the repair of the mitral. And this is the 5th patient. This is a quite interesting case because we scan her as a routine scan, and we found incidental funding of a type E dissection in a patient that was completely asymptomatic. Now, the dissection originated just below the arch, so we don't think it's correlated with the stent because we say that maybe the area can be high risk after the stent is just when the stent finished, that it will be so after the nominate artery, and so extend this, for 6-7 millimeter this dissection, and reach a maximum diameter of 43. But I mean, we know from the natural history of this MAFFON patient that this is the history actually of MAFFON patient. The main issue is also after conventional surgical repair, they can have further dissection in other part of the aorta. And actually, maybe this supports the idea that this patient, she's a quite high risk of dissection, and the proximal bit has been supported by the stent. She's 133 kilos, so she's a very obese patient, so we are keeping an eye and try to be as conservative as we can. And this is the Bristol patient, again, very good follow-up at CT scan, and the harrow showed the region of a coronary artery, and again, the mitral repair is very successful. So just to summarize, so the mitral dysfunction is the second most common cardiac manifestation in MAFFON patients. So I think its role is quite underestimated. 60-80% of patients with MAFFON syndrome have mitral valve prolapse, and 1 in 8 develop a moderate to severe mitral regurgitation at the age of 30. So MAFFON syndrome is not just aortic disease. There's a big component also of the mitral disease. And these mitrals are very technically repaired usually because there is bileaflet prolapse. The characteristics are elongated rupture cord, thin leaflet, and severely dilated and calcified annuli. So we know that we can achieve from study from big center, we can achieve good long-term durability of the repair, but the best management of the root in this patient is controversial. And maybe the personalized aortic root support may represent an ideal solution. So why? Because we show it doesn't add significant complexity to the surgery. It doesn't impact on the surgical ischemic time. And so this means give more time to the surgeon to dedicate for complex mitral valve repair technique. And potentially can give some long-term benefit in terms of reduce the risk of aortic dilatation, aortic dissection, and need for reoperation for the treatment of the proximal aorta. And obviously avoid anticoagulation and support also the annulus and prevent the aortic valve regurgitation. Obviously, a large number of patients are required, a longer follow-up. These are just our early results, but they are very encouraging. I would like to thank Mr. Petru for sharing his extensive experience with this technique and with all his aortic experience, and support my career and my research projects so far. And I would like to invite all the students, junior doctor and senior colleagues with an interest of aortic surgery to contact and visit the aortic team. You're welcome to come to our theater. As I say, mainly on Wednesday we do this big aortic case. And these are the contacts if you want to contact us. Many thanks.
Thank you very much, Renata and Mario. So I'm going to take you a few years back and reveal my age, unfortunately. 1988, I was a registrar in cardiac surgery in Sheffield. And there was a symposium where Donald Ross was chairing, Magdi Yacoub was there, Tom Treasure, you know, all the guys. And they were talking about thoracic aorta surgery. And I can tell you the mortality at the time was 2 figures. Your results are spectacular when you quote a 0% mortality. Why is that? Are you a better surgeon? Or is it the technology? Or is it the support and the physiological conditions with bypass, doing things without bypass? What is it? What's made the difference over a period of 30 years?
Thanks for the question. And obviously, you mentioned some great aortic surgeons. So I don't think the difference is in a surgical skills. The question is that now the system is different. We work in a big team, and the MDT discussion is very important because we plan our surgery very carefully. We do a lot of redo operation, and the preoperative CT scanning has changed a lot that result because we are able to access the risk of reaccess the chest and use other strategy to avoid the risk of major complication during the reopening. That is a big part of our activity. And the role of intraoperative TOE is fundamental because we have a constant we have a good planning, intraoperative last-minute planning for what we have to do. We check our cardioplegia distribution. That is very important because myocardial protection is very important. And we check the result of our repair in theater, and we are able to fine-tune the repair. So it's really a team effort, and we found it's very important to have a team and expert scrub nurse and assistant and anesthetist to optimize the blood management. Is a teamwork, and the cardiologist before very helpful to plan the surgery.
Thank you very much. It's the first time I hear surgeons talk about physicians to say that they are health. Okay, thank you.